Just an open house session. So, yeah, students who have joined, they can start. Saurav, Jasmeet, Hari Prasad. Saurav, you want to?
Yeah, shall I start, or do you want to give an introduction or some such thing? Okay, I'll start. Yeah. Good morning, and it's nice to be part of your vibrant tutorial and sessions and online sessions. This is the first time I'm participating in your, although I've heard about this. Now, today's topic is acute pancreatitis. And to start with, acute pancreatitis is a bad disease. Bad because we don't have a real cure for it. Second is the presentation, the behavior of the disease itself and the response to treatment is so varied that you cannot have a cookbook approach for any of the problems in acute pancreatitis, right from the presentation, diagnosis, and stratifying and treatment strategies. So all the more reason you should concentrate on the clinical behavior of the disease in a person rather than depend on the standard guidelines you have, of which you have plenty of them. Guidelines, as the name implies, are only to guide you, not to mandate your treatment decisions. This is the first thing I think you should remember when you are dealing with acute pancreatitis. To start with, I'll just share 2 or 3 slides, just to get you into the See, the acute pancreatitis is not as bad as it was, say, maybe 2-3 decades back. There have been quite a few developments, and it's important to know these developments because you don't want to reinvent the wheel. Now we have a clear understanding of the clinical course of the disease. We are able to put the patient in exactly the timeline for an acute pancreatitis, where exactly he is. Even if we are not sure of the exact onset timing of the disease. So you know whether he is in the first week, or second or third weeks, which are more crucial, or in the midst of complications. And you have a redefined terminology, which is important because of the vagueness of the terminology. One was not able to compare your experience with others' experience, nor even in your own experience to formulate your own treatment pathways unless you have a clear, defined, well-defined terminology. Now that terminology has been redefined and it is fairly clear and it is almost universally followed. And like many terminology, you may have some problems, but then that is only... I mean, it's not uncommon considering the varied nature of highly heterogeneous nature of the disease. Intensive care is one thing which has improved our results in acute care, and as a surgeon you should be well aware of the intensive care principles of these patients, when to shift them to an intensive care, and how to monitor them during the intensive care, working along with your intensivist, your gastroenterologist, or imagiologist. It's become a multidisciplinary care. So before you treat these patients, you should develop how to coordinate with your multidisciplinary team, particularly the intensivist. Conflicts are common. How to resolve the conflicts. These are very essential soft skills you must achieve when you're treating this kind of patients. And the other crucial development is the step-up approach. Or as a surgeon, it might look a little paradoxical that you are delaying surgery as much as possible, to the extent of even not opting for surgery. sometimes. So that is after burning our fingers for 1 or 2 decades. Now we know that a step-up approach, the minimalistic approach to drain the offending fluid or the solid necrotic material, and stepping up to more invasive techniques has yielded better results than straight away going for surgery at a most inopportune time. You also have a good selection of patients, and selection, more important than on that even, is timing of your intervention. These are the things which have improved your results, and before you start treating, it's important to remember these basic principles. Now, as you see, it's also important to know how an acute pancreatitis behaves. This is also important to place yourself exactly in which situation the patient is right now. We should remember that more than, say, 85% of the patients settle within a week. They have only what is called mild acute pancreatitis, whereas the rest of the 15%, 1/3 are sterile necrosis, and the rest, 2/3, may be infected necrosis, comprising 15% of the total necrotizing pancreatitis. So you are basically treating only this percent. These patients would most often either get treated in the peripheral centers or with your medical colleagues or elsewhere or at home itself. So this is not, we'll get into these things. So the revised Atlanta classification is another important terminology you must remember, that I don't know whether we can start asking questions now, or maybe after this we'll start. So you have the mild acute pancreatitis, which has no organ failure or systemic complications and generally resolves in the first week itself, and a moderately severe acute pancreatitis, which is a new entity now, where you've realized that the organ failure, which you might see in the first 48 hours, is not always persisting. And it's not right to get them labeled as severe acute pancreatitis and apply all your guns. So these people, they have only a transient organ failure, and if they are detected on time and appropriately treated, particularly with their fluid management and intensive care, they would resolve back to their normal, near normal status. Now, it's important to recognize these patients so that you don't overdo things. And then the severe acute pancreatitis, where you have a persistent organ failure, which persists more than 48 hours. So you should not stratify these patients in the first 48 hours. It is not that simple to, because they can either be moderately severe or severe acute pancreatitis. Both of them would require a different approach to diagnosis and treatment. So let's see the presentation, say how they might present. Now, see, this is a kind of not an uncommon presentation. A 47-year-old overweight woman is admitted with generalized abdominal pain. She has been unable to eat or drink due to nausea and vomiting. And she states that the pain had started in the right upper quadrant suddenly 6 hours ago, but is now in the epigastric region. An ultrasound obtained on her last visit to the emergency department revealed gallstones with no inflammation of the gallbladder, and she was told that she should see a surgeon. She looks jaundiced and in distress, and she has point tenderness in the upper abdomen, which has worsened with deep palpation. There's no mass palpable. Now, this is the kind of, I'll have to get out of this now, I think. How would you?
Yeah, you can stop sharing.
Yeah, that is what I'm trying to share. Okay. No.
I think if you click at the bottom of your screen.
The bottom of the screen is okay. Sorry.
Either at the bottom or at the top.
Sir, we can keep the questions on the slide mode. And Kapoor sir, you can ask the students which one want to reply, because the questions will not be seen by the attendees after the removing the slides.
Can you have both at the same time? It's also possible to have presentation and this one also at the same time.
Yeah, I can read the chat, no problem. So any student who wants to ask anything, you can unmute yourself and come in. No problem. Yes. So maybe I can start asking on their behalf. So first, the clinical diagnosis, like in this case which you presented, if you can go back to your previous slide. This could be acute cholecystitis also.
Yes. This could very well be an acute cholecystitis, but then there are certain features which may not be in favor of that, or maybe you have to think a little more into that, because she has been referred to you with a problem. See, acute cholecystitis is not an uncommon thing. She is an overweight woman. She is a known cholelithiasis, and she has the emergency department did not reveal, and an ultrasound done as an emergency did not show inflammation of the gallbladder, although it showed gallstones. Now this is a kind of situation where you have to think of something else also. On the other hand, say you have a patient like this, a presentation like this. A 53-year-old man presents to the emergency department with severe mid-epigastric abdominal pain that radiates to the back. The pain evolved over 1 hour. He also describes nausea, vomiting, and anorexia, and gives a history of alcoholic intake over many years, including this past week. He is tachycardic, tachypneic, febrile with hypotension. He is slightly agitated and confused. He is sweating, tender in the epigastric region, with guarding and rebound tenderness. Now, this is a more classical presentation of acute pancreatitis. So now, can somebody say how exactly do you clinically diagnose acute pancreatitis? What are the features you would expect to strongly suspect acute pancreatitis? Can somebody answer that?
One of the students, Dilip, can you come in? Dilip, Dr. Dilip. How do you diagnose acute pancreatitis? What are the criteria? Prachin?
Yes, sir.
Yes. Yes, please. How do you diagnose acute pancreatitis? Prachin? We can't hear you. Any other student wants to come in? Jasmeet, Saurav?
Somebody is trying to say something, but is not audible.
Prachin is trying to speak, but we are not able to hear him. So maybe some other student can come in. Saurav Chaudhary?
The classical pain
Yes.
of epigastric pain with radiation to back and a biochemical evidence of amylase.
Yeah, we have not come to the biochemical evidences yet. We have only a clinical presentation here. Exactly. What you said is quite right, but it should be a little more explicit. Say the epigastric or upper abdominal pain radiating to the back and classically starts after either a heavy meal or an alcohol bout. It may be accompanied by nausea, vomiting, and 80% of the times it radiates to the back. These would be the classical historical features which would make you suspect acute pancreatitis. Now you have this kind of patients. What exactly would you like to do in this patient? It's already showing. Okay. Unless
yeah, Aman, you were there. You can continue, Dr. Aman.
Yes, sir. I would like to get a. I'll examine the patient and
yes.
I'll assess for his her vitals, her pulse, her BP, her urine output in the last 1 hour, and her abdominal examination, along with the respiratory status. After
Yeah, that is all standard. So, what exactly is your intention now?
Sir,
what do you expect to find?
The patient may be tachycardic, her pulse rate may be increased, she may be having tachypnea due to the pain or due to the pain, and the abdominal examination may show mild tenderness in the upper abdomen. But the abdominal examination is more important to rule out other causes than to diagnose acute pancreatitis. There may not be any specific finding for acute pancreatitis, but yes, the other abdominal catastrophes may be ruled out, like a perforation or a obstruction.
Yeah, they may not be ruled out, but at least you should suspect. So what exactly would you like to do? We are quite right in assessing the vital signs to start with, which also includes the respiration and oxygen saturation. Yes. When you do all that, after you do all that, you are still not certain about acute pancreatitis or any other condition. How exactly would you proceed now?
So I would like to do a chest X-ray erect and an X-ray abdomen erect.
Chest X-ray is the first one you want to do? With what intention?
X-ray abdomen erect. The chest X-ray is the best investigation to see for pneumoperitoneum if there is a perforation. And X-ray abdomen erect to find for the any obstructive features in the bowel. There may be telltale signs of pancreatitis in the form of colon cutoff.
You are quite right. You are quite right in investigating for ruling out other problems. But what is your priority here? What are are you really seriously thinking of other possibilities? In an emergency situation, you have to prioritize yourself. You also need to confirm what you are suspecting. You said you are strongly suspecting acute pancreatitis. So would you like to do any investigations to confirm your diagnosis?
I'll do a serum amylase, serum lipase, sir.
Yeah, exactly. Because that will be the diagnostic feature of acute pancreatitis. In addition to the classical clinical presentation of pain, the serum amylase and lipase would be your next investigations. And how exactly would you interpret them?
Sir, serum amylase is highly sensitive and but not very specific for pancreatitis.
How much? What level? What level?
Serum amylase is sensitive in upward of 95%.
No. What level of, say, a serum amylase of what value?
More than 3 times. Yes. 3 times the upper limit of the normal of that lab.
Yes, exactly. So it should be, and you want to do amylase and lipase or one of them?
Sir, if asked for just one test, then amylase. Otherwise, I'll get both of them done. Because lipase is specific, it takes time to rise, but it is more specific.
And lipase is longer lasting than amylase.
Yes.
Than amylase. So what are the caveats? Say when you think serum amylase would not rise, what are the situations where it may not be that sensitive?
If it is acute on chronic pancreatitis, that is the pancreas is already burnt out and isn't producing any more amylase.
Exactly.
So amylase may be normal.
Yes.
Also, amylase may be falsely raised in multitude of abdominal catastrophes.
That will be specificity. That will be specificity. Yeah.
Yes.
It may be raised in maybe about 10% of other situations like acute even cholangitis or impaired renal function or intestinal ischemia or intestinal obstruction and other diseases. Yes, exactly. So it's also important, but it is crucial. And do you think time any does it impair the value of amylase? Supposing the patient presents after in the first on the fourth day of his illness,
Sir,
then is
neither
it
the
maximum
value,
sensitive?
sir, that I don't know, sir.
Uh, as I said, say the lipase value persists for more time than amylase, even amylase up to 3 days, whereas the lipase sometimes up to 6 or 7 days.
Okay, sir.
But it's best in the first 24 hours.
Yes,
So
okay.
yeah. So what other things you assess in this patient? You would look for, you
I
assess the
do,
hemodynamic status? Yes.
yes, sir. I like to do once the diagnosis is confirmed.
Yes.
Apart from the Atlanta classification, there are other severity scores. So for that, I would like to do a room air ABG, complete blood count, including the hemoglobin, total leukocyte count, platelet count, and the hematocrit. Along with that, the liver function test, kidney function test, blood urea creatinine electrolytes, and CRP, along with also procal and interleukin 6 to assess
Procal now
the
itself? Okay. What is...
sir, baseline would help me gauge what increment means, because otherwise single value of procal may not be very
what is the significance of procal?
sir, in any bacterial infections or major stresses to the body, major surgery, procalcitonin rises.
So, are you expecting infection at this stage?
No, sir.
No.
Not.
So, procal has more value when you are suspecting infection than in SIRS. See here, so you must remember in the first week of acute pancreatitis, particularly the severe acute pancreatitis, what you are interested in assessing is the patient in SIRS, in SIRS, isn't it? Not
Yes,
the
sir. Yes, sir.
infection. Infection is very uncommon at this
Second week.
stage.
Yes, sir.
So, how exactly? What is SIRS, and how do you assess, and what is its significance now?
Sir, SIRS is
What are the components of SIRS?
systemic inflammatory response syndrome, temperature less than 36 degrees Celsius or more than 38 degrees Celsius,
Yes.
pulse rate more than 90,
Yeah.
respiratory rate more than 20, and TLC count more than 12,000.
Or less than 4,000.
Or less than 4,000, yes.
Yeah. Yeah. See, now SIRS in most of the centers has become the important combination of investigations to assess the acuteness in the first week. See, although you have a lot of other stratification score systems, none of the score system has really stood the test of time.
Yes.
They only tend to delay the management of the patient and are not that sensitive, and they are cumbersome. So most of the centers have really given up, except for the multi-organ failures. Supposing the SIRS is severe and you are expecting a multi-organ failure, which can also happen in the first week, you must look for the signs of multi-organ failure. How exactly would you test for or evaluate for multi-organ failure at this stage?
Sir, one is the gross clinical picture. Apart from that, the lab tests will help. So
You are not audible now.
Sir, we have clinical apart and added to it the lab investigation.
When you say multi-organ, which organs are you interested in? It's simpler if you identify the organs and the crucial organs which tend to fail.
Which organs are more important than others? Several organs fail, but there are some organs which are more important.
Hello?
Yeah.
Yes, sir. Sir, we are looking at the respiratory status, the acute lung injury, ARDS. We are looking at cardiac status in the form of...
For respiratory status, what exactly do you want to do to assess the MOF?
Sir, we can do the one is bedside quick SOFA test. One is actually quantifying according to the modified Marshall score. The quick SOFA score is respiratory rate more than 22, GCS less than 15, and systolic BP less than 100. Otherwise, the Marshall score classifies all organ failures into as per the severity. So for acute lung injury, we have a PaO2 to FiO2 ratio.
Exactly. Yes.
The PaO2 to FiO2 ratio is more than 300. It is grade 1. If it is between 300 to 200, so patient has acute lung injury. That is grade 2, and grade 3 is PaO2 to FiO2. ARDS when it is less than 200.
Correct, exactly. So you would evaluate for multi-organ failure also at this stage itself, apart from SIRS. Are there any other factors which would identify high-risk patients? Because there may be some factors which may not fall in these groups, your Marshalls or SIRS. So what are those high-risk identifiers? Can you name them?
CRP at presentation is more than 150.
Yeah, CRP is one.
Hematocrit fall is there. The serum calcium for over 48 hours, there is a fall of more than 2. Those are the other indirect indicators.
There are others like say the obesity. An obese person is a high risk patient, and age more than 55, and other comorbid diseases also. So these are the other things which you would assess. And when exactly would you like to, where exactly would you like to treat them? Say you want to shift them to ICU. Are there any criteria?
So patients who are in acute lung injury, who have 2 or less organ failures, can be managed in the HDU high dependency unit.
So basically, you look at the original Atlanta, revised Atlanta criteria for organ failure, and it's you decide to shift them to ICU. So we're dealing with a diagnosed case of acute pancreatitis now. So how would you now? What is your treatment modality? How exactly would you treat these patients? Your treatment options and priorities.
Sir, patients who have mild acute pancreatitis may be managed in the HDU or may be managed in the ward, taking care of their nutrition, the urine output, and watching for development of any infection. Those who have severe acute pancreatitis usually are going to have a long hospital course, and such patients have to have aggressive nutrition management, aggressive fluid hydration, along with.
You have to prioritize them. Nutrition is okay, but do you think fluid status is more important than anything else in the initial 48 hours, 24 hours?
So your voice had got cut, sir.
No, I agree with the nutrition part, but do you think the fluid management is much more important in the first 24, 48 hours?
Sir, actually, importance of fluid management, there are 2 schools of thought. One used to say to be aggressive. Previously,
what is the current balanced view?
To give goal-directed fluid therapy.
Goal-directed fluid therapy, and there is absolutely no controversy as to improving assessing their fluid status and keeping them well hydrated. There's absolutely no controversy there. The controversy used to be how aggressive you need to be in that and what kind of fluid you need to give. So what is the current recommendation for fluid management?
We have to first go ahead with crystalloids only to ensure an adequate urine output. By adequate urine output, it means 0.5 to 1 ml per kg per hour. More than that, and the crystalloids would be the first choice.
Yes. So what would be the crystalloid? You have either normal saline or Ringer lactate?
Ringer's lactate, sir.
Okay. Any particular advantage with Ringer lactate?
sir, balanced salt solutions are preferred because the plain normal saline can lead to hyperchloremic metabolic acidosis.
Large amounts of normal saline may lead to hyperchloremic acidosis, which will further aggravate the trypsinogen activity. Yeah, that is when you are giving very large amounts of saline. But actually, there is no robust evidence of one over the other. You can either give normal saline or ringer lactate. There may be a weak evidence for ringer lactate as a balanced solution. One, second, as it may have some anti-inflammatory properties. Say that is weak evidence. So it is not important as to what kind of fluid you give, but that you are giving good amount of fluid and hydrating the patient. So what would you're talking of goal-directed therapy. What apart from the urine output, you said 0.5 to 1 ml per hour. How would you start your fluids, and what are the other goals?
So the other goals are end organ perfusion should be good. The patient should appear hydrated. The eyes should be sunken. The tongue should not be dry.
That is subjective. Any objective signs? Anything lactate, objective?
So the serum lactate, which may be done on a venous sample, should be either normal or coming towards normal. So less than 1 or 0.5 till 2, I am happy.
Do you think serum lactate is related to the fluid management?
The lactate is overall marker of the general health. So
no, we are talking of specifically fluid management. And what are your goals? Do you think lactate will be affected by large amounts of ringer lactate?
No, sir. But end organ hypoperfusion is reflected in the form of raised lactate. The lactate has nothing. The ringer's lactate has nothing to do with serum lactate. So that is converted to bicarbonate in the liver. But if there is organ dysfunction, if there is organ hypoperfusion, the serum lactate starts to rise. So if the fluid hydration is adequate,
may I interrupt, sir?
Yeah, please. Yes.
Just another question. You're not identified the cause of acute pancreatitis. None of the investigations you mentioned tell you what is the cause.
Yes, sir.
It's very important to remember that if you know the cause needs to be treated before the pancreatitis becomes severe. One example is hypercalcemia. Second example is hyperlipidemia. And then history and knowledge of any drugs having been taken. For example, in an AIDS patient, heart therapy would have been one of the etiological factors for acute pancreatitis. It's very important to do concurrent investigation into the etiology in addition to stratifying the patient with pancreatitis. One interesting observation has been that if the serum calcium is normal, then you should suspect a parathyroid cause and a hypercalcemia. You won't get a high calcium in the first 4 to 5 days.
Yeah, it's quite right. But as you see, when you're prioritizing the issues, the majority of acute pancreatitis you see are either alcoholic or biliary. And you must consider the other causes when you don't have these two and then atypical presentations. And when the risk factors are not suggestive of any of these, yes, you should consider. But when you are prioritizing the management here, we are talking of fluid management, which is common irrespective of the etiology. So while it is important to consider the other causes, the fluid management, see, this is just a summary of the fluid management. Replacement in the first 24 to 44 hours is crucial, and it is associated with a reduction in morbidity and mortality. Persistent hemoconcentration at 24 hours is associated with necrotizing pancreatitis because of the microcirculatory effect and the vascular leak syndromes. So goal-directed fluid therapy, the clinical assessment is heart rate, mean arterial pressure, and urine output. Hematocrit blood urea nitrogen, creatinine, CVP, stroke volume, and IVC filling, which are assessed at frequent intervals to follow the goal-directed fluid therapy. So the goals, as mentioned, are heart rate less than 120, mean arterial pressure of 65 to 85. I hope you know what is MAP. How exactly do you define MAP? Anybody? Can you hear me?
Any other student wants to come in? Yes, Aman.
Systolic pressure and 1/3 of diastolic pressure.
Is it 1/3 of diastolic pressure? 1/3 of pulse pressure. Diastolic pressure plus 1/3 of pulse pressure, which is systolic pressure minus diastolic. See, these are all fundamental things you should not fumble in the exam. It gives a bad impression. But MAP is by and large, it's detected by the invasive monitors these days. So you're very rarely you are calculating them. So and the urine output, of course, you mentioned, and the hematocrit. Hematocrit coming down is another important goal. So how exactly, how much of fluid will you give? I'm concentrating a little on fluid because this is a recent observation, and this is actually only one of the very few things which we have in control to prevent necrosis or patient going into complications of either compartment syndrome or necrosis. So how would you start your fluid management? How much of fluid will you start with? What rate? You said crystalloid, yes, Ringer lactate or normal saline. But how much and for how long? You also mentioned how you monitor it.
Aman, you can continue.
Sir, we'll start with maintenance. We'll start with IV bolus of 100 to 200 ml per kg and assess the urine output and then get to a maintenance requirement. Usually
100 ml per kg may be a little too little. 100 ml per hour you're saying. How much are you saying? 100 ml per hour.
The 100 to 200 ml bolus over 15 to 20 minutes, assess the urine output. Usually the maintenance comes between 80 to 100 ml per hour.
Well, the current standard is 5 to 10 ml per kg per hour of isotonic crystalloid, either normal saline or Ringer lactate, unless you have other cardiovascular factors or renal factors which may reduce. Say 5 to 10 ml per kg is a significant amount. It is still a high amount. Now, the monitoring is done by this, but bolus, yes, if a patient is grossly dehydrated and on the verge of hypotension, yes, you might give a liter in 1 hour and then continue with this kind of fluid. So it's also important to limit aggressive fluid resuscitation to first 24 to 48 hours. When the patient is presented after 48 hours, it is better not to persist with aggressive fluid, because by this time changes may have taken place and you might precipitate abdominal compartment syndrome by inducing capillary leaks, and that would be much more difficult to control than the eventual necrosis, which might have started by this time. So after 48 hours, aggressive fluids is not advisable. Just a side thing, now fluid management in all the other situations where you require large amount of fluid, you must remember that there are 4 phases of fluid therapy. The resuscitation phase, where you give large amounts, you optimize, stabilize, and then de-escalation concept. The 4th one is during the de-resuscitation is a crucial one to remove the excess fluid. The aggressive resuscitation sometimes leads to a lot of problems of tissue edema, intestinal edema, as you would see on the table when the anesthetists are aggressive. And the same situation may apply to acute pancreatitis also. So This concept you must remember. Okay. Apart from fluid management, what other things you would take care of now? What about antibiotics? What is the current status? When would you like to start antibiotics, and what is a role?
Although there is no robust evidence of starting empirical antibiotics, unless there are signs of infection or sepsis, but most of the
Not
time,
a robust evidence. There is no evidence at all.
yes, sir.
Yeah.
But routinely we do start broad spectrum antibiotics, sir.
For all patients, it's acute pancreatitis.
With severe acute pancreatitis.
Severe acute pancreatitis, many times they have already started by the time the patient is referred to you because of their defensive reactions. But there is theoretically, and there is absolutely no role for antibiotics in SIRS phase, which these patients are in. Unless they have other infections, like say cholangitis or respiratory infection or a thrombophlebitis or lung infections, which are a different indication for antibiotics, and which also occur in say about 15 to 20% of these patients. So per se, antibiotics have no role. What about biliary pancreatitis and endoscopic intervention? When is the right time, and what are the indications?
Sir, in patients with severe acute pancreatitis showing a CBD stone with cholangitis, in the early phase, it may be done to relieve the biliary obstruction or the cholangitis. If there is,
the only indication is cholangitis.
Yes, sir.
While that obstruction, yes, obstruction again is still a debated thing now because of the problems of ERCP itself and the invasive nature of it, and it aggravating the pancreatitis. One would hesitate unless there is a clear cholangitis. Yes. While that obstruction with endoscopic, with MRI or endoscopic ultrasound evidence, unless you have that, which is causing, say you have a stone in the lower end, which is causing dilatation of the proximal ductal system, ERCPs people are hesitant to do. Cholangitis is definitely an indication. So even ERCPs, the endoscopists have become less aggressive. Unlike previous times when the mere diagnosis of biliary pancreatitis was enough to rush in the patient to the endoscopy suite and do a sphincterotomy. Nutrition is the other important thing. You want to add anything else?
No, sir, and to watch for signs of infection and to decide when to do a CT.
We will come to that. Nutrition, yes. Nutrition is important. We know the enteric nutrition is important, and it's better started as soon as possible. If the patient does not have vomitings or he doesn't have ileus, not gross abdomen, even if he has an abdominal distension, you must give him trial oral feeds, and if he is tolerating, you should continue the enteral feeds. And if oral feeds are not tolerated, we might do a nasogastric or even nasojejunal feeds for these patients. So this is over. Okay. So now we've sort of started the treatment in the first week, and how exactly would you monitor these patients in the first week?
So their vitals, the urine output, the nutritional oral intake.
We have not talked of any imaging in the first week. An ultrasound probably as you mentioned in the initial assessment, a plain X-ray or X-ray just to rule out other conditions. But to assess the acute pancreatitis and its sequelae, after 5 or 6 days is the best time. Unless you have an atypical presentation like the first presentation which you have shown, or the diagnosis in doubt, or the amylase lipase are equivocal. In such cases, when the diagnosis cannot be confirmed, you might like to do a CT scan.
We will do an early CT in those cases. Apart from them, for assessing severity, we'll do it after 48 to 72 hours.
After 5-6 days, not even 48, 72 hours.
Okay.
Yeah.
Okay. After 5 to 6 days to assess for both the local complications and associated respiratory complications. In the local complications, we'll grade the pancreatitis, see the hypoperfusion or the non-enhancing part, how much part of pancreas is involved. Also, the peripancreatic fluid collections, any necrotic collections, the solid component, any drainable collection, if there is some CT evidence of infection in the form of air foci.
No. We are still talking of first week.
Yes,
We are in the first week only. It's very unusual to have infected pancreatic necrosis at this stage. At this stage, either you have an interstitial pancreatitis or a necrotic pancreatitis or acute fluid collections.
Yes, sir.
So these are the three things. And how exactly would you identify the necrotic areas by hypoperfused areas?
The normal pancreas would enhance in the arterial phase. The hypoperfused or the non-enhancing pancreas is the one which has undergone necrosis. Along with that, there would be pancreatic edema and there may be fat standing around the perirenal and the lateroconal fascia and the gerota along that, along with the classical signs of in the classical signs like colon cutoff, the sentinel jejunal.
They're all okay. They're all indirect signs. So basically, your monitoring is directed towards knowing whether the patient is maintained on the status in his first as his presentation, or is improving, or there is a failure of management, or there are complications. To look at all these, you would continue to do further investigations and including an image. This I just show one or two images. Say now, how exactly would you interpret this image?
Sir, in the first one,
yeah,
there is actually a gallstone is also there, sir.
Yeah.
A radiographic gallstone is there in the gallbladder. Oral contrast has been given.
Yeah.
And the pancreas is throughout bulky with fluid collection in the body tail region where the arrow is pointing.
Fluid collection is not there, but then there is edema, yes.
Edema is there, the pancreatic capsule has been lifted off because of the edema.
So what would you call this? Are there any hypodense areas?
No, sir. The pancreas is uniformly enhancing in the picture.
So this would go as interstitial pancreatitis, isn't it? Yeah. Whereas the second one?
Second one, the arrow is probably point the...
So this is okay, a little bulky pancreas, but it's here you are seeing fluid.
Yes, sir.
So this is still an interstitial pancreatitis, but with acute fluid collection. There are still no hypodense areas.
Yes.
So this is still can go as either mild acute pancreatitis or intermediate, but just acute fluid collection, and it's in the first week only.
Sir, in the first image, no contrast has, no arterial or venous contrast, no venous contrast has been given. So, would it be right to comment interstitial pancreatitis on that?
Yeah, even in when you are not given contrast, it will show some hypodense or irregular areas. Yeah, this is always the first phase. For time thing, I'm not giving all the other features, but this is enough to say that that is acute interstitial pancreatitis. Now, on the other hand, say you have a CT of this. How will you interpret this?
The pancreas
this is with contrast, yes.
This is arterial contrast. The pancreas is only focally enhancing at the arrowhead areas. Apart from that, the pancreas is not enhancing. Along with that, there is a large lesser sac collection which is pushing the stomach anteriorly and the left in relation to the left lobe and tracking along the left paracolic region along the speed.
If you see the difference between the second one in the previous screen and this is a little heterogeneous, and there are hypodense areas here. So there is a lot of peripancreatic necrosis here. It is not just an acute fluid collection.
Yes, sir. Okay.
So this would go as necrotizing pancreatitis, and see, you don't still have signs of infection there, or it's walled off. It is diffuse.
Yes, sir.
Whereas now here,
Sir, there is air foci with gas formation,
yes,
which are mostly telltale signs of an infection developing in it. And along
there
with
is a lot of peripancreatic necrosis.
fat standing as well.
Yeah, a lot of peripancreatic necrosis and the gas. So it's very important to interpret imaging at this stage in the second week. From second week onwards, it's crucial, because that is the one, apart from the clinical presentation of clinical manifestation of sepsis, which you should not miss. These are the two crucial things, and you will also monitor for the sequelae of sepsis, which are on the renal and the respiratory systems. Now, okay, so forget all this. So how will you now assess, and what kind of actions will you take? What are the concerns at this stage? You have, say, an interstitial pancreatitis, but the patient seems to be settling. So you would continue the same, and you would not treat him in ICU. In any case, the mild acute pancreatitis does not require ICU treatment. What other things would you advise for a mild acute pancreatitis?
Sir, I'll take help of the gastroenterology colleagues to assess for the cause of it, and if it's a treatable one.
So you can do that yourself. As Desai was saying, you see, your main interest at this stage is biliary pancreatitis. If the gallstones are present in mild acute pancreatitis, they deserve a cholecystectomy before the discharge.
Yes, I'm the same thing.
Isn't it? So that is an important part of mild acute pancreatitis.
Okay, sir.
Whereas in other necrotizing pancreatitis, what are your concerns, and how will you assess the progress?
Sir, I'll continue to watch for nutrition.
Yes.
Assess for nutrition, assess for any signs of developing, any signs of any infection setting in sepsis, and worsening vitals and surge.
How exactly would you assess for sepsis?
Sir, if the patient throws a fever spike, has worsening tachycardia, his counts increase, along with abdominal signs of some guarding or
yeah, as we know, in acute pancreatitis, necrotizing pancreatitis, the worsening situation is in two phases. The first phase we have crossed. So as the patient is settling and is worsening, now as fresh worsening would indicate that there is probably sepsis, most likely sepsis. Apart from the telltale signs of sepsis, which are increasing fever spikes, increasing leukocytosis, and the most important sign is, when such a thing is happening, you would repeat an imaging and look for signs of sepsis, which is mostly the gas. So gas in the necrotic areas, and you would also try to assess whether the necrotic areas which you have seen before are tending to localize. Are they getting walled off? Although you may not take immediate action, you would look for the tendency to wall off, and what are the areas which are where necrosis is present. What are the areas where necrosis is generally present in the peripancreatic areas? It's important to know a bit of peritoneal anatomy here. Yes.
So mostly it is in the lesser sac, which is approach, which may be approached to the gastrocolic ligament,
Yeah.
It can track along the left and right paracolic gutters.
Yes.
Also, it can go up to the pelvis, but mostly it is in the lesser sac and tracks along the left and right paracolic gutters.
Yeah. Say this. So this is the lesser sac behind the stomach, and then the mesocolon, and into the mesentery, and the retroperitoneal, paracolic, paranephric, perinephric areas, right or down into the pelvis, and on either side, right and left. These are the areas the necrosis is likely to spread into the lesser sac here, into the mesentery here, right paracolic space, Morrison's pouch, left paracolic space, and mesentery. It's important to localize the areas of necrotic spread, because your intervention is dependent, the type of intervention may be dependent on the location of the necrosis. Which would be the most ideal situations for the necrosis for you to treat among these anatomical spaces?
When it is limited to the retroperitoneum, mostly in the lesser sac and left paracolic. So a ward or a percutaneous drainage
Yes.
may be done in these areas more commonly and easily.
Yeah, it's close to the posterior abdominal wall or lateral abdominal wall, either on the right or left, and immediately behind the stomach. Not all the entire lesser sac may not be accessible. Central necrotic areas are the most difficult to treat. Into the mesentery and into the mesocolon, they are the most difficult to treat with less invasive techniques. Because we are getting into the necrosis. See, these are the areas. See, this is the necrosis, lot of gas there, and the spaces. See, the left anterior pararenal space here, and the left paracolic space. This is the most difficult area for you to treat. Gastrohepatic ligament and into the porta hepatis. This would be the difficult area for minimally invasive techniques. Percutaneous nowadays, almost 90-95% they are able to access all the spaces, but then followed by any other invasive technique, it becomes a little more risky. On the other hand, the lateral spaces and the posterior spaces, and immediately behind the stomach, for an endoscopic approach, which is getting more and more popular, the localization of the space and clear interpretation of your imaging is crucial. Okay, so what would be your indications for an intervention when you have necrosis?
But Sastry, I think we are at 10, so maybe we will have to.
Yeah. That's why I'm hurrying through. So, what would be the indications for intervention?
If the patient has signs of sepsis along with CT evidence of infected pancreatic necrosis or infected collection, then we'll take an ultrasound. We can take an aspiration FNAC to send for culture and drain the collection. With a percutaneous drainage, pigtail, or upgraded to a thal set if the output is less, or there are more of solid components.
Yes. To be more specific, a clinical sepsis is an indication with a large amount of necrosis. Because even with sepsis, we know that some of the patients do get well with simple antibiotics. So the antibiotic cover definitely is the most crucial in these patients. At least a proportion of them would get away without any intervention. So that is a new realization. And if you have definitely gas on a CT, you would definitely be in a hurry, or you would be more inclined to drain them percutaneously, or if it is behind the stomach, endoscopically, and you have the other ways of draining them, either laparoscopically or retroperitoneoscope or an open surgery, particularly when you have in the central areas, as we mentioned, in the mesentery and the mesocolon and the gastrocolicum, and the lateral areas are spared. There you might even like to do open surgery straight away. So multiple operative techniques are there, multiple operative accesses, and they all are the variation of the same theme, which is so these are see, the best scenario is when you get at a mold like this and leaving behind a totally normal area. That would be the best time of timing for removing the necrotic material by an open surgery. If you want to, if you have any further questions on this, I think we are approaching time. Running out. Yes.
নিয়ে গেছিলাম সই করে নিয়ে এসেছি বসুন একটা ডেস্কে 5 মিনিট
Let's okay. Let's get away from this. Just ask since
I have a
beyond
question,
10, so maybe we will.
Yeah.
If any student wants to ask anything from Dr. Sastry,
I want to ask, sir.
Yeah. Please.
Please go ahead.
Sir, please can you briefly outline both for colonic fistula and duodenal fistula patients who require surgery? What would be your procedure of choice?
Colonic fistula, intestinal fistula is a serious matter with acute pancreatitis because of the infection and because of the invasive sepsis that might. So when you have a colonic fistula, you would suspect when you have a large amount of air in a necrotic area, in the perinecrotic area, apart from infection, you might also suspect hollow viscous perforation. So that would definitely be an indication for surgery. And a colonic, if you can mobilize that bit of colon through the necrotic area, exteriorize it, that would be the best. Otherwise, you might just drain it and do a proximal drainage and an ileostomy for diverting these. So the procedure, the type of procedure would depend totally on the local hostility of tissues. Why I am saying this is because while trying to attempt, mobilizing the colon through this necrotic mess, you might injure more tissues, you might have large amounts of bleed. So it's sometimes you may have just to be satisfied with draining that area with a good drainage with a proximal diversion. The best would be to exteriorize that segment.
But diversion loop ileostomy doesn't usually divert fully, sir. So
yeah, it doesn't completely divert, but still that would be the best. If in certain circumstances, if you have a proximal diversion close to the area of fistula, that would be good, but that is not always possible because of the shrinkage of tissues, because of the necrotic involvement of the mesocolon. It may not always be possible, but that would be the only option.
And the duodenal medial wall fistula?
Very unusual. Very unusual. You will have to treat them like a duodenal injury, duodenal viscerals, again with either a proximal diversion, feeding jejunum. Any of these procedures, of course, you would do a feeding jejunostomy. But duodenal fistula has to be treated like any other duodenal fistula with a proximal diversion and a good drainage of that area with either a sump suction or a good drainage. You have various other procedures for a duodenal injury and viscera which may not be feasible with pancreatic necrosis. So it's a very serious complication. Unusual. Duodenal injury is very unusual.
Okay. Thank you.
Any other question?
Yes.
As you know, sir, most common indication of ERCP in case of biliary pancreatitis is a cholangitis, sir.
Yes.
When the patient comes to us with a cholangitis, patient having raised OTPT, sir. Like this patient having OTPT around more than 3 times or 4 times in the range of approximately 152. But we'll say the persistent obstruction will be the indication of this ERC, no, sir?
Yeah.
As the next day the OTPT reduced and then we'll not do the ERC, or should we proceed?
Now, persistent biliary obstruction because of a stone is a debated issue. You don't have a clear, absolutely clear, universally accepted guideline here. That is definitely treated as an indication for endoscopic intervention. But before you do that, you must have an MRCP, or even better will be an endoscopic ultrasound to exactly localize that the stone is obstructing the lower end, and it is not just a stone which is asymptomatic. But a symptomatic bile duct obstruction definitely is an indication for endoscopic intervention for sphincteroplasty, but not, the timing may not be as urgent as in cholangitis.
Okay, sir.
So I think we can close. Thank you, Dr. Sastry. Thank you very much. And we hope and expect you to have some more sessions. I know there are so many other topics which are of your interest, including GI bleeds. So I think we will have.
Oh yeah, definitely, yes. Anytime you are welcome. I thoroughly
Students, please
enjoyed
send me
this.
a mail, vkkapoor.india@gmail.com. Just write acute pancreatitis. I will send you that chapter from my unpublished book. And Aman, since you volunteered to take all the questions, you can ask for one extra chapter. So just mention what extra chapter you want. I'll send you 2 chapters then.
Really grateful, sir. Thank you, sir.
Thank you. Thank you. I see Dr. Richa also joining. Richa, you want to say something, especially about the management of pancreatitis in children, which may be different?
I just want to thank Dr. Sastry. It was so nice to see him after a long time, and he's as enthusiastic as he was 10 years ago.
Okay.
So if you want to add anything to the subject, yeah, I missed coming to Lucknow. I was supposed to come to Lucknow, but I couldn't. Yeah, it is nice to see you, Richa.
Thank you, sir. Thank you.
Thank you, Dr. Sastry. Thank you very much.
Thank you,
So, Anand,
Dr.
shall we close? Anand?
Yes, sir. Yes, sir. Yes, sir.
Okay.
Thank you, sir.
Thank you.
Thank you, everyone.
Thank you. Thank you, Rajen. Thank you for joining. Good night from me, everybody. 11:30 for me in the US here. Okay.